make sure that you can hear me? This is Louise.
Yeah.
Great.
Devin, your video is on.
Press *6 to unmute.
It's a web, but I see anything but a billion people following him.
Hello. Can you hear me? Okay. It's Sir from CICC Fishers. Hello, this is Debbie. Hi, Braxter at CICC Fishers in Indianapolis. Have you started?
I don't think so.
We have not started yet.
I can
all right.
see the screen. I can hear some things in the background. I just want to make sure.
Yeah, same here. Yeah, me too. Mine's Debbie, too, with UPMC Cancer Center.
Well, that's funny. What city are you in?
Park.
I'm sorry? Okay. Sure.
Can everyone see the slide deck that's being presented?
Yeah.
Yeah. Oh, mine just came up. I don't think they started yet.
Everyone everyone who's on the line, we haven't yet started the webinar. We'll probably start in just a few minutes. We're just waiting for everybody to hop on because we had to approve some last-minute registrations. While we're waiting for people to join, you'll notice that you were probably muted upon entry. You can unmute yourself by clicking on the microphone at the right on your computer, or there's an option, I believe it's like *6 on your phones. We would ask that everyone stay on mute while the presenters are speaking. That way we don't get a lot of background noise. If you do have a question during the talks while everyone is speaking, please either raise your hand or you can use the chat function, and if you respond to everyone, everyone will be able to see your question, or you can respond directly to myself as the host and I will share the question. But preferable to respond to everyone, and that way we can be answering questions as we go along through the chat function. Thank you.
Thank you. Jeff, can you hear me now?
She said it's going to take a few minutes. Because not everybody's on. She sent slides.
Hello?
I can hear you.
Okay.
Pardon me? It's not on yet. Okay, now I'll lost everything.
I lost control.
Somebody presentation rights. Let me find you again.
Yeah, there it is.
All right, thank you.
Everyone on the line, please not change yourself to presenter or ask for control rights. We have one person kind of controlling the slides for the day, and we'd like to allow her to keep presentation rights for now.
Yeah, I see that Dr. Herbst and Dr. Eidelman are on. Do you think we can go ahead and get started?
Yes, I think we can go ahead and get started. I think the speakers that I've been able to catch should be unmuted unless they've remuted themselves. So welcome everyone to the Lung Map webinar. This is the fall 2017 update. Thank you for joining us. We're pleased to have you here. As I said, please not play around too much with the presentation rights, as we have one person who will be controlling the slides for the day for all the speakers, and we'd like her to be able to retain that ability. We would also please ask that if you are not speaking, that you keep yourself on mute so that we don't get a lot of background noise for the speakers. We will be recording this session, so hopefully we can put it up on the SWOG website and make it available to everyone who could not attend. Practical things. If you have a question, please use the chat function. Please reply to everyone. We will have a few people answering the chats as we move along. If you have any sort of issue with that, please use the function to raise your hand, and one of us will try and walk through the process of using the chat function. We'll open up for questions at the end, and we will hopefully do that using the raise the hand function as well. I think that's it for our logistics. Welcome again, and I will turn it over to Crystal and the presentation team. Thank you.
Thanks, Stacy. Dr. Herbst is going to provide the introduction to the webinar first.
And we really appreciate everyone joining us today for this webinar to trial, talk about the active studies. The agenda for today start by updating a Lung Map partnership and collaboration, the current schema, the tissue screening at P versus pre-screening. As you know, both mechanisms are available, and then a summary of the open studies for F and I, some discussion of immune-related adverse events, 1400 VCP, which we'll describe what that is. Then a summary of the upcoming sub-studies, 1400K and 100GEN. And then we'll talk about some form changes. This will be a whole group of us talking quality assurance and monitoring, and study protocol structure and revision status. So, we'll have a full hour. The master protocol really has been a collaboration between so many different groups, and this slide shows that. Master protocol really is the central hub where we have all the cooperative groups that take care of adult patients in the United States, ECOG Akron, NRG, CCTG, Alliance, and SWOG, and the NCI, along with the FNAH, which have just been essential for this, working closely with Friends of Cancer Research, been in this from the very beginning, and then of course advisory input, the FDA. Of course, all the trials get, any results would be sent to them for review, with the FDA really involved. And here are the partners. You can see it's a large group of partners, the ones I mentioned, as well as the companies. This is a public-private partnership. The drugs are coming from the companies. The Foundation Medicine is doing the profiling, and then we're bringing the agents to the patients using the cooperative group mechanism. Well, here's the current lung map schema. You can see that the studies fall into two groups: biomarker-driven sub-studies and non-match sub-studies. As you know, when you screen these patients, and I know many on the phone have been involved in this, we'll get a finding, a genomic abnormality that would put someone in the biomarker-driven side of the fence. And then on the that went before I was done, and then the non-max sub-studies. So there are a number of completed studies. The GDC 0032 is completed. The palbociclib is completed. The AZD 4547 is completed. The otulimumab, aratinib versus alatinib, that closed quite early in the course. But we have three arms for which we have data. We found patients and we've studied the drugs in that context. You can see the new arms that have opened. The BMN 673, that's a PARP inhibitor, and the CMET armed antibody, eagerly awaited in the new year. And then for non-max sub-studies, patients that don't match, we completed the study of MEDI 14736, also known as durvalumab. And then very exciting trials still open. The checkpoint-naive patients, nivolumab, ipilimumab versus nivolumab, that's open and accruing very well. And then just recently opened, and we're excited about it here at Yale at my site too, 1400F. So if someone's checkpoint refractory, and then get the MEDI 14736 or tremelimumab. 1400Gen, this is an ancillary study for all participants looking at some genetic markers. So next slide. I'll turn it over to Dr. Edelman. I don't hear Edelman.
John, did you use the call-in function?
Looks like.
Dr. Hurst, do you mind going ahead and going over the screening tissue?
So absolutely, and when Marty comes, he can pick it up. But now you know. So really, a great effort, a team effort. So many men involved. Over 1,400 patients enrolled. So we wanted to talk a little bit about screening for tissue. Now, patients can participate in screening in one of two ways. Either option one, they screen at progression on prior treatment, or they can be pre-screened prior to progression on current treatment. So background noise, if you're not speaking, if you could please put your phone on mute, I think that would be helpful. So there are two ways to do it. You can pre-screen, so you're seeing the patient and you're starting your frontline chemotherapy, send it off and get a pre-screen, or you can screen at progression on prior treatment. Here are the criteria for pre-screening: current be for stage 4 or recurrent disease, must have received at least one dose of the current regimen, must have previously received or currently be receiving a platinum-based chemotherapy regimen or anti-PD-1, PD-L1 therapy. So someone on nivolumab, pembrolizumab, atezolizumab. The sub-study has its own eligibility criteria to the labs, history, and et cetera. So eligibility for screening, pre-screening doesn't imply eligibility for the sub-studies. So it's a multiple turnstile mechanism. Next, please. One of the advantages of pre-screening, and I appreciate all the support we had from the companies, from the NCI, FNIH, when we instituted this several years back. It assures that the specimen can be obtained and is adequate. It eliminates the lag time that results in patient anxiety when they've progressed. And honestly, we all know that when we start someone on chemotherapy with stage 4 lung cancer, they are going to progress. Provide rapid assessment for trial eligibility at the time of progression, 24 hours versus 2 weeks. And as we know, it can sometimes be longer than that. Here's an example scenario where pre-screen was utilized. Smith had stage 4 lung cancer, non-small cell. He is receiving carbogemcitabine and is doing well after 2 cycles. He's been consented and was pre-screened, retrieved from the archives, and evaluated for adequacy by a local pathologist. The patient is registered to this S1400 screening. She was submitted and foundation analysis performed. After cycle 4, he is found to have progressive disease. The notice of progression form gets submitted in and she is able to be assigned on the trial the next day. Seamless transfer to the next therapy for the patient. And of course, that's the most important goal. Next slide. So now, hopefully this handoff, this baton goes a little bit better to Dr. Lale, who's going to tell us about the really exciting 1400F, which I mentioned just opened. Natasha.
Great, thank you so much. I hope this technology worked and you can hear me. So as Roy said, and thanks Roy, we're really excited about this study. S1400F was put together by the LungMat team and Dr. Meyer Risby at Columbia and myself. And it's one of the non-matched studies, but unlike S1400I, it's actually for patients who have also had a PD-1 checkpoint inhibitor. So if your patients had platinum, they're eligible for LungMat, and they've also had, let's say, nivolumab or pembrolizumab, they would be potential candidates for this study if they don't have a match on their genetic testing. So we're doing this, we're combining durvalumab and tremelimumab. You get both drugs once a month for 4 cycles, and then after that you get durvalumab maintenance. We're predominantly looking at response, but we're also looking at a number of other endpoints, and the real question that underlines this trial is, one checkpoint inhibitor doesn't work, can we overcome resistance to that by adding a second? And so in terms of your patient's past history, you're eligible if they never responded to the nivolumab or pembrolizumab or atezolizumab. They're also eligible if they initially responded but later progressed. And so we're looking for about 60 patients. We've got our first patient on already. We're really excited about that. And we look forward to seeing some more patients from your site.
Thank you, Dr. Yo. Dr. Herbst, would you like to provide a summary of the open sub-studies?
Sure. So the open sub-studies shown here, there's S1400G. That's a PARP inhibitor study for homologous recombination DNA repair deficiency, otherwise known as HRRD, who is particularly receptive to treatment with PARP inhibitors. This is through this screen, a number of different variants and genes that are involved in DNA repair. Seek to evaluate the efficacy of talzoparib, a potent PARP inhibitor in such patients. Includes genes with alterations in BRCA1 and 2, ATM, CHEK1, and other homologous recombination repair genes. And this is a list, subject to some discretion and some, it's a very evolving field of research, but I think we have a very modern list that we're following. Talzoparib will be administered orally once daily. It's in 21-day cycles. Treatment will continue in some patients until disease progression or intolerable toxicity. This is open and accruing, and actually accruing quite well. Next slide. So now, I guess we're going to turn it over to Ludmila, the S1400I, who's going to give us a little summary of the status of that sub-study. Ludmila.
Okay, so S1400I has been open since December of 2015, going relatively well. It's a randomized phase III study. It's one of the two non-matched studies, those whose molecular profile did not match a targeted therapy and who have not been treated previously with checkpoint inhibitors. So the difference between 1400I and 1400F is 1400I is for patients who are immunotherapy naive, and 1400F is for patients who have been exposed to immunotherapy. The primary endpoint of the study is overall survival, and in the patients who are randomized to either monotherapy with nivolumab or ipilimumab plus nivolumab. Arm 1 of the study is a combo arm, so nivolumab given at a standard dose, standard schedule every 2 weeks, and then ipilimumab is given on a more extended schedule every third cycle, and the arm 2 is nivolumab by itself, administered as for FDA approval day 1 on every 14-day cycle. The treatment on the study, patients are treated until disease progression or intolerable toxicity. Just remember that. Do you want me to continue? Because
that's
I'm
quite a fanfare there.
Yeah. So, okay, good. No, I still hear music. So the patients will continue on the study until disease progression or intolerable toxicity. Remember that post-progression therapy is out certain patients who meet a certain criteria, which is spelled in the protocol very well. Next slide, please. So we found a couple of very useful resources for you that you can use for patients who are treated on 1400F as well as 1400I to help you manage adverse events. So the presentation slides from last webinars and a couple of links to publications and useful resources for you. So far, what we have seen in S1400I is that the combination arm side effects do not appear to be significantly different than their side effects from the monotherapy arm, kind of releasing our concern that combo arm might not be well tolerated, but the study so far has not been shown that. And I think that's my last slide.
I'm Crystal Meaver. I am the project manager for S1400 and all of its sub-studies. LungMap has grown to where we've completed 5 trials, we've opened 3, and we've got 3 new ones on the way. We're trying to figure out different ways to reduce some of the regulatory burden for this trial. So what we have done is we've taken the main study or the screening protocol and each of the sub-studies, and they've been broken out into the individual documents. To be able to keep track of all of the changes and the version dates for each of these studies, we've implemented the version control protocol. The idea with the version control protocol is that it will keep track of all of the revisions that are made to each study independently, so that revisions can be made to the individual sub-studies without affecting the other sub-studies. This will come in very handy with small revisions that just need a quick fix here or there, or major ones when we're talking about NCI mandating a request for rapid amendment or a new sub-study that's being added. The version control protocol includes 2 tables. It lists each of the versions and the current version of each of the components of the LungMap. This version control protocol is going to be very handy, especially as we move forward with the different versions and adding on new substudies. So please make sure that you're always looking at this protocol. Right now it's housed on the DSU website on S1400 abstract under the supplement documents. Please let me know if you do have any questions in regards to this protocol version. And we'll turn it back over to Dr. Roy Herbst for upcoming substudies S1400K and S1400 Gen.
Okay, thanks, Crystal. This is something.
Can I ask a quick question?
Yes.
Hi, this is Stephanie from Baptist South Lexington. I noticed on the EDC they've added that they want the verdict. Is that document, the VCP document you just talked about, going to be retroactive where we can go in and see when, so it'll sort of compilation of all the changes that have happened, where we could go easily look at this time, this is the protocol version that we were on?
Correct.
Thank you.
Thanks, Crystal. So now this is Roy again. I'm going to talk about 1400K. So this very exciting sub-study. It's a biomarker sub-study with eligibility defined as by c-Met positive squamous cell as follows. IFC positive based on the Ventana SP44 assay, and it's looking for an H score of greater than 150. So we're looking for c-Met on the surface of cells. Why? Because we want to look at the overall response rate with sotuvimab vedotin. I guess call it ABBV399 or 399. It's an armed antibody in all patients with c-Met positive lung cancer, squamous cell carcinoma. So basically, the c-Met is used as the address to bring the antibody to the tumor, and it's got a payload, which is a toxin, like a chemotherapy, which then kills the tumor. ABV399 will be administered intravenously on day 1 of a 21-day cycle. Will continue in consenting patients until disease progression or tolerable toxicity. And the accrual goal is 44 patients, assuming prevalence of the greater than 150 H score of 30%. Now, S1400Gen, as I promised I would talk to you more about, is an ancillary study. It's evaluating patient and physician knowledge, attitudes, and preferences related to the return of genomic results in 1400. We're working with Scott Ramsey and his team at the Fred Hutchinson Cancer Center. This is what one would call an outcomes study, patient-reported outcomes. How do patients feel about this entire process? And of course, that's critical, because we want to make sure that the quality of life and the way the patient feels is improved. So we need to study this. All U.S. English language-speaking patients registered to the S1400 Master Protocol are eligible for participation in this ancillary study. They're conducted over the phone, 25 to 30 minutes or less to complete. The idea is to recruit and survey 30 study physicians also that are providing care to patients enrolled in S1400 ancillary study. An online survey, 15 to 20 minutes or less to complete. So patients and physicians, what are their knowledge-based attitudes and preferences regarding these results? Next slide. So I'm going to pass it off in a second, but that's a very nice, this shows the lung map has multiple, goals and multiple areas where it's focused. Certainly new drugs, targets, therapies, but also looking at patient perceptions, which are very important. So I'll turn it over to Louise.
My name is Louise. I'm one of the data coordinators for the Lung Map trial here at the SWOG Statistics and Data Management Center in Seattle. And I know I've spoken to a lot of you on the phone or over email. So I'm just getting into some of the details regarding recent updates to the EDC for a few Lung Map sub-studies. So in early October, we released revision 9 and 10, which was a combined release of 2 revisions in one. And this release included some forms changes and involved some retrospective data collection, specifically for our sub-studies that utilize immunotherapeutic agents, which at this time were S1400A and S1400I. So we'll start quickly with A. This change applied only to patients that were enrolled on the MEDI 4736 arm. And since this substudy was closed at the time, it's a retrospective change only. It had a relevant patient that was enrolled on MEDI 4736. You should have received an email a little bit after release of the EDC changes detailing those changes. I'm not going to go into too much detail, but the basic idea was we were asking for identification of immune-related adverse events. Next slide. of what those changes looked on the EDC. These pretty screenshots come straight from our data entry guidelines document, and I just wanted to highlight that for a second. If you haven't accessed it before, I highly recommend checking it out. It's available both in the SWOG ORP manual and on the protocol page, the S1400 protocol page on the SWOG and CTSU websites. And it contains a lot of detailed information regarding data entry and RAVE. So for 1400A, we were simply asking that any immune-related adverse events be identified as such in the EDC. Next slide. S4I contains some more extensive changes, and it does apply to both arms and patients on the study, since both arms of S1400I involve an immunotherapeutic drug. And patients are still on treatment on this substudy and also actively accruing. These changes apply both retrospectively and prospectively. And in the future, keep an eye out for similar data forms on S1400F and on any future substudies that involve immunotherapeutic agents. We were asking for identification of immune-related adverse events on those substudies as well. So next slide and show you some screenshots. This looks like on the main adverse events report form. We have a question up at the top that asks whether any adverse events in the reporting period were immune-related. If the answer to that is yes, then you have to go through each log line on that form and identify which ones out of the events were considered immune-related. We have a question at the top in order to make it a little easier on you. If there were no immune-related adverse events, you just have to answer no once and not go through every event in the cycle. We also added a field for the CTEP errors report ticket. This field only needs to be entered if that particular adverse event was reported as an SAE via the CTEP errors expedited reporting system. We enter the ticket number there so that we can correlate between the two systems. And answer yes to the question, is the AE immune related? Then an additional supplemental form will generate, and if we can go to the next slide. That's what that form looks like. It's pretty short. We tried to limit the amount of information. The form will roll out per immune-related adverse event per cycle. The reporting period will be automatically filled in based on the adverse event reporting period. And we just ask a few questions regarding what the impact on the treatment was and whether any meds were needed to treat the immune-related adverse event. For instance, steroids is a common one. And next slide. A change that occurred on S1400I. As Dr. Bazanova mentioned, S1400I has another special attribute, which is that patients can remain on disease if they're continuing to clinically benefit from the treatment in the opinion of the treating investigator. And this, with Revision 9 and 10, we also changed that the follow-up tumor assessment folders will roll out specific for those patients who remain on treatment after progression. And we, go ahead to the next slide. You can see that we added a question to the follow-up tumor assessment that asks, will the patient continue to receive protocol treatment? And that means after the assessment was done. If yes, and the patient has also progressed, you will have new follow-up tumor assessment forms roll out while the patient remains on treatment. And that is so that we can continue to collect any information regarding scans that were done while the patient remains on treatment. We know this was not a requirement in the past, so we are asking for you to provide any information that you can about any scans that were done while the patient remained on treatment, but we know that they might not follow the protocol schedule, or you might have the full information available. And if you have any questions about this or about any of the retrospective data collection, please get in touch with the SWOG Data Operations Center. Our contact information is at the end of this presentation as well as in the protocol. And last slide, so I just wanted to say a big thank you to everyone who has been working on entering this retrospective data, and we really appreciate your efforts. Don't forget to reach out with questions.
This is
Thank you, Louise. Yes, I can hear you.
Okay. I'm just going to go over some of the common things we see when we come out for audits, and one of the first things I will cover is what we see with regulatory. With regulatory, when we review your informed consents, they have to match the your boilerplate language and the CIRB approved model. And for the most part, sites are getting better at this, although we do still see some variations. Any changes to the model have to be in your boilerplate word for word. If there's one word different, that's seen as a deficiency. One of the most common areas we see this is sometimes when revisions come out, there will things are added to the consent, and sites are pretty good about adding them, but when things are taken out of the consent, sometimes the sites leave them in there in the consent, so that creates a variation. So be conscious that you're taking the parts of the consent out that need to be removed with the revisions, as well as putting the additions in. For the boilerplate document also, we have seen at sites that usually when they start up the study, there's a protocol-specific boilerplate document, and then annually sites update this with the CIRB. When we come out, we compare your consent to the most recent update, and usually that's the annual signatory consent boilerplate. So you have to make sure that when your annual one changes, that you also make those updates to your CIRB approved consent. Requirement is a delegation of task logs. It's always been a requirement of SWOG that you have a delegation of task log or a site authority form. And what we're looking for now is with NCI's changes with the registrations that are required within the CTSU, what we are looking at is what people are assigned to be, that they are to do. This NCI they are doing now is requiring people to register, and they're actually making sure that everybody's qualified to do what they're being assigned to do. And so when we come out, we are going to look and make sure that one thing is that it's up to date, and the other thing is if somebody on it is assigned things appropriately and they're allowed within the delegation of task log to do those tasks. The NCI has given us presentations at each of the group meetings and saying that basically anybody doing anything within a research study need to be on this delegation of task logs. It's currently our view that basically if you're doing something that's standard of care, for instance, if you have an ophthalmologist reviewing an eye issue or a surgeon reviewing or saying whether or not something is surgically resectable, or perhaps a treatment nurse administering agents, those things are all within their scope of practice, and therefore they would not necessarily be required to be on the delegation of task log. Next slide, please. Other things we see in eligibility, we're still seeing some issues where the percent of vital tissue is not confirmed prior to registration, although this is getting a lot better. Basically, it's part of the eligibility that is confirmed prior to sending the tissue off. When you send the tissue to Foundation Medicine, they run the test and they charge our grant, and so therefore we want to make sure that the tests being ran or the tissue being reviewed actually would be able to have the test done to it. With the S1400G, there has been a question about the response in the eligibility criteria that states that you have to have a response to the initial platinum therapy with your first response assessment, and that's basically because the drug telazoprid has been seen as being most responsive and most effective in that group of patients, and that's why that is in there. The other thing we see in eligibility is for many of these studies, you cannot have corticosteroids administered systemically within 14 days prior to study registration. There always seems to be some kind of documentation saying that the patient will stop these, but many times there is not a date of saying that the patient stopped on this date. So we can't tell if the patient actually stopped 14 days before. So make sure that if they are on corticosteroids, that they do have documentation of the exact date that they stopped those. Next slide, please. Other things we see for treatment, some of these studies require dose modifications or maybe treatment to be held for grade 2 toxicity. I think everybody working with SWOG studies for a long time knows that there's probably dose modifications for grade 3, but you don't always think that there may be dose modifications for grade 2. So it's important to look back at your Section 8 of the protocol of the sub-studies and make sure that if a patient has a grade 2 toxicity that you're not supposed to hold a reduced dose for that. The other thing is failure to document compliance to oral drugs. What times we see is we may see that something saying the patient continues to take drug. However, when we go in on it and we are checking off the amount of drug given, which is given in total dose, we will see some kind of documentation of how many pills the patient took so that we can check that with a milligrams total dose you have entered actually equals something which in the documentation. Adverse events, we still see a lot of failure to report adverse events. Generally, this is because a lot of sites don't record labs that are not clinically significant. It's very common for pharmaceutical studies to say not want or exclude those from reporting. However, SWOG's protocol states to report all adverse events. It does not exclude those. So make sure even if they're not clinically significant that they would be reported. Case report form guidelines, which is available, I believe, on CTSU. I know it's available on SWOG's webpage, actually go over what needs to be reported and how to report them. This would be on page 27 of that if you want to get more information. The other thing is what Crystal was talking about earlier with the immune relationships for adverse events. A lot of places have a log that they track adverse events where they say what grade they are, when they started, when they stopped, and what relationship they are. However, a lot of those logs do not have anything on it about immune relationships. And what we see sometimes is that you'll have a patient who perhaps has hepatitis and they're put on a steroid, decreasing steroids, but then the RAVE will report that it's not immune related. So it's really important, whatever your source document you have, that you actually go and add that question to it, whether or not it's immune related or not. Next slide, please. Kind of goes over the adverse event page, which is on in the clinical report guidelines. And what this is we're adverse events assessed during this time period. Basically, if they have anything that's even non-clinically significant, you would say yes that they had adverse events during this time period. Next slide, please. This kind of goes over the same slide that Crystal had earlier. The only thing I want to say is that when you're collecting retrospective information, when you're going to be getting all those immune-related responses for S1400A or I that have happened in the past, what we've kind of suggested and what we will accept is what you can do is in the bottom, when you look at RAVE, on the bottom left-hand corner, there's a thing that, a little button that says printable version. You can actually put that up and just have your investigator check off or write yes or indicate on there which ones were immune related, and that way you can use that as a source document and we'll accept that. Next slide, please. For the data entry errors, one of the things we see is the current date of staging that continues to be an issue. What a lot of people put down for that is they'll put down the date the doctor saw the patient, or they'll put down perhaps when they had their surgery. But we consider any time point that they've had a scan or maybe a biopsy be the date of staging, and that could be after those time points. So basically, whatever scan or procedure you have related to staging closest to registration, that's going to be your current staging date, not necessarily when the doctor saw the patient. T&M staging, we sometimes see some variations in that. A lot of people would enter what the patient stage was at diagnosis, and what happens is if they're now stage 4 disease, you have to say M1B or M1A on the form. So we want the stage at registration, not necessarily at diagnosis. For symptoms, number of symptoms, systemic treatments for stage 4. Sometimes we see people enter, if they've had radiation, is a systemic treatment. Radiation is not a systemic treatment. This would only be drugs that are given orally or IV related. Sometimes people put a stage 3B treatment in there too. We only are asking for stage 4. The data on uploaded reports, sometimes what we see for that is that people will put the date of the report and not the date of the procedure, and that's most commonly seen with a pathology report. But pathology reports generally have their dates of the report maybe a day or two after the procedure. You should be entering the date of the procedure, not the date on the report. Measured creatinine clearance. Sites are still entering a value in the measured creatinine clearance. What measured creatinine clearance means is that you took 24 hours of urine and you measured the creatinine in those 24 hours. So if you didn't measure 24 hours worth of urine, that line of case report form should be left blank. I think that comes into play because what the case report form does is it automatically calculates the creatinine clearance based on the weight you entered in the creatinine, and then people feel like they have to enter their calculation in there as well. But you should be leaving that blank. Can you go to the next slide, please? For the RESIST criteria, sometimes what we're seeing that is people may be listing too many lesions. According to our protocol section 10, you're going to be listing 2 lesions per organ and 5 lesions in total. So if you have 4 lesions in the lung, you're only going to put your best 2 in there, and the other 2 would be going over to the non-target lesions. And for lymph nodes, I still see some sites that are recording the largest diameter instead of the smallest. So you have to make sure that the smallest diameter is greater than 1.5, or they would be considered non-measurable. Next slide, please. Target lesions, again, these would be things like effusions, bone disease, and the other thing to consider is that sometimes what we see is lymph nodes that maybe are measured as, let's say, 0.5 millimeters. Those shouldn't be listed as target lesions because if they're less than 1 centimeter, then they're considered non-pathologic. Slide, please. Data submission and triad and specimen submission. Sometimes what we see is people, usually for the for CTEP regulations, anything over 3 months is considered delayed, but for baseline forms, SWOG has a different requirement, and basically anything over 30 days late is a lesser, anything over 90 days late is a major, and that's only for baseline forms. Your follow-up forms would go by the 3-month and 6-month rule. For triad, we also that our submissions also are required within 7 days of the disease assessment. For your baseline triad, they go by the 30-day and 90-day rule. For your follow-up scans, it would be the 3-month and 6-month rule. For specimen tracking, when you collect a specimen, they're allowed to be batched. However, sometimes when we audit, if they're batched or not submitted, we don't have any idea that they have been drawn. So if you're drawing and batching, if you could at least go into specimen tracking and log that they have been drawn. You do not have to ship them when you log them in. So if you could go ahead and log them as drawn, it would allow us to know that they've actually been done. Next slide. I think that might be it. Yeah. Thank you.
Thank you. Mary Redmond?
Everybody, thank you for listening so far. I think I just have a couple of slides and just to share some of the exciting plans that we have for LungMap. So as really nicely discussed earlier, we have several studies that are in the works, but we also, as part of those major revisions, have a planned expansion of the trial. And you heard described earlier, the study population for the current LungMap is previously treated stage 4 recurrent disease with squamous histology. And with a planned expansion of the trial, we're going to be allowing all histologic types of non-small cell lung cancer. And behind that is that we think that immunotherapy and even biomarker-driven therapies are probably not, their benefit may not be restricted to just squamous histology, and so we felt that it was important to be more inclusive. And as part of expansion, we are going to be augmenting the component of the trial that's circled in red doing evaluations of therapies for patients who have received both platinum and immunotherapy for their disease. And so currently we have S1400F, which is the study with 4736 and tremelimumab, and that's just for squamous histology. But we're doing a new study, S1400, that we're evaluating an immunotherapy combination in patients with all histologic types of non-small cell lung cancer. We'll be retaining S1400I, the nivolumab ipilimumab study, in just squamous patients, and the marker studies may be done in squamous only, non-squamous only, or both. And so we're being just a little bit more flexible as we start moving forward. The intention is to expand to these expansions sometime in the first quarter-ish or first half of 2018. Next slide. We have a few studies that are in development that, and so the non-match study that we have in development is S1400L, which is looking at a drug by rucaparib, which is another PARP inhibitor, and be a biomarker-driven study in genomic LOH positive patients, and looking at all non-small cell lung cancer patients. We would be 2 cohorts of patients, squamous and non-squamous patients, and we anticipate the positivity, the biomarker positivity rate for this study is going to be between 12 and 16%. We also have, well, as I mentioned, we have a new non-match study for patients who've previously received immunotherapy. And the first one that we expect to be implementing is the study with pembrolizumab and ramucirumab, and we're incredibly excited about this study. And there's future combinations that we're evaluating. There's the potential for looking at nivolumab and rucaparib, that same PARP inhibitor from Clovis. So for our new planned studies, we're very excited about our new developing studies. Go ahead and finish this session with just saying that we always want to hear from you and answer any questions that you have. And presented on this slide are your contacts for if you have eligibility, imaging, and data submission questions. If you have article and regulatory questions and have funding questions, please don't hesitate to contact us. And, okay, this is my slide too. And then just to remind everyone, we do have a site coordinators committee, and we think they are an incredibly important part of the study. And the mission of the site coordinators committee is to represent study staff at the SING, CRA, data management, and regulatory level, providing feedback to and from the study leadership to enhance accrual and improve study management. The chair and co-chair of the study are Jessica Jordan and Lavinia Dobrea, and their email address is also listed at the bottom of that slide. So if there are any things that you heard about today or that you've experienced while enrolling patients on this trial, please contact them, and they'd be happy to work with you as well. So for your participation, and I will turn this back over, I believe, to Crystal to manage. We would any questions that you have from this seminar. Thank you.
Thank you, Dr. Mary Redmond. I have seen, if you do have any questions, please feel free to add them to the chat box and include to send to everyone. I have seen a couple come through. The first one being the anticipation activation dates for the new sub-study S1400K and the survey S1400Gen. We're in the final stages of this. It's actually being reviewed by the CIRB later this month. So we are anticipating that it being active in January of next year.
Yeah.
Now, if anybody wanted to raise their hand or anything or have any additional questions, I'm happy to speak.
Okay.
Does anybody have any questions?
Are there questions in the queue?
Question from Deb Shaw. The delegation logs, are we now going to CTSU or are they new paper forms?
when we come on site, at the paper form. But what's going to happen in the future, and I'm not exactly sure what date it's going to be, but it's probably going to be sometime in 2018, the NCI is going to flip to the electronic form to the CTSU. When we come out, though, up on that mandatory time for it, we are giving, if you have a problem with it, we're giving it lesser deficiencies as opposed to major because it's a new requirement. But the NCI or the CTSU requires it and it all goes into place, then if you do have a problem, we'll be considering it a major. But for right now, we're just looking at the paper form. And on our website, on the QA page, is a model or template that you could use if you don't have one already.
Now that you had your hand raised, did you still have a question?
I do. So on the ARM F, in the toxicity management section, you all have management guidelines for amylase and lipase, but yet we aren't monitoring that. We're not even checking it at baseline. So was it an oversight that we didn't add it to the protocol? Was this something that was pulled over from ARM-I, or are you just putting those guidelines in there in case we would draw these and find that we're having amylase and lipase issues?
So, Natasha, would you be able to answer that?
Sure. So I think because it wasn't part of the routine, we were measuring it routinely, but we did want to make sure, because it's a common occurrence, that it did occur, that you have management guidelines. But we will go back with the team and just review whether we need to add it. Hopefully not. I think actually we felt that we weren't going to add it routinely. We weren't going to change the routine blood work. But just to give you some additional guidelines. We'll go back and we'll revisit that.
Brenda, you had a question? See, if Brenda doesn't have any questions, did anybody else have a question? If you come across any questions in regards to this file, please reach out to us. We will answer your questions as quickly as we can. This is a great team that I work with, and I really appreciate everyone being able to take time out of your day and participate on this webinar. So thank you very much, and you all have a good day.